topic of today is advanced life support. This is the algorithm before the start of ALS. You should always check whether there are signs of life. When there are no signs of life, you should immediately start the CPR 30/2 ratio and follow the basics of BLS. When there are signs of life, use ABCDE principles and reassess patient regularly. In the next slides, we will show realistic situations. The first situation is a female patient of 43 years old on the AE collapsing. The patient is still able to speak and shows clear signs of breathing. In this case, monitor ABCDE principle and reassess patient regularly. The second situation is a 84-year-old male patient on AE collapsing and feeling unwell. 1 minute later, there are no signs of life. In this case, you should immediately start the 30/2 ratio CPR. The crucial principle in ALS is the rhythm. You have on one side the shockable versus on the other side the non-shockable. In the next slides, the different rhythms will be discussed. After assessing this principle, immediately resume CPR for 2 minutes and restart assessments of the rhythm if no improvement is seen. Step 1. Rhythm. To assess the patient's rhythm, a 12-lead electrocardiogram is needed. Also, a knowledge of the electrocardiogram rhythm is mandatory for ALS. VF is an abnormal heart rhythm in which the ventricles of the heart quiver instead of pumping normally. It is due to disorganized electrical activity. VF results in cardiac arrest with loss of consciousness and no pulse. This is followed by death in the absence of treatment. On the electrocardiogram here below, you see clearly irregular QRS complexes, and the diagnosis is by showing irregular unformed QRS complexes without any clear P waves. In the pulseless ventricular tachycardia rhythm, the patient will be pulseless, and the rhythm originates in the ventricles. This is in contrast to other types of tachycardias, which have origination above the ventricular tissue. Pulselessness with a tachyarrhythmia occurs because the ventricles are not effectively moving blood out of the heart and there is therefore no cardiac output. Many tachyarrhythmias of a rate above 150 will deteriorate into pulselessness if timely treatment is not given. Pulseless electrical activity, PEA, refers to cardiac arrest, in which the electrocardiogram shows a heart rhythm that should produce a pulse, but it does not in reality. Asystole is the absence of ventricular contractions in the context of a lethal heart arrhythmia. It is the most serious form of cardiac arrest and is usually irreversible. A cardiac flatline is a state of total cessation of electrical activity from the heart, which means no tissue contraction from the heart muscle and therefore no blood flow to the rest of the body. The VF and pulseless VT are shockable rhythms and receive one shock admission. Immediately after this shock admission, you should continue CPR 30/2. After this shock, you should continue 2 minutes of CPR, and after this, you should assess the rhythm. PEA and asystole are two non-shockable rhythms, so do not perform shock and continue CPR and assess after 2 minutes the rhythm. The bradycardia algorithm will be discussed step by step how to perform it. It consists mainly of PEA, AV blocks and asystole. The adverse signs are shock, syncope, myocardial ischemia, heart failure. If the patient is not stable, proceed to step 1. If the patient is stable, proceed to step 2. Step 1. Unstable patient with an adverse reaction, for example, a shock. You can admit to 3 synchronized direct current shocks, and after the shocks, you give amiodarone 300 milligrams IV over 10 minutes. After this, you repeat the direct current shock, followed by another shot of amiodarone, but now you give 900 milligrams over 24 hours. Step 2. Atropine 0.5 milligrams. If the patient is stable and does not have any of the adverse signs, then you give 0.5 milligrams atropine. After this, you reassess the response of the patient. The 0.5 milligrams atropine works, so we proceed to step 3A. You observe the patient and reassess regularly. In the case that the rhythm is one of these, a recent asystole or a Mobitz 2 AV block or a complete heart block with broad QRS or ventricular pause, then you continue to step 3B and you continue with the admission of atropine 0.5 milligrams. Step 3B, readmit atropine. So, in the case of one of these, a recent asystole or a Mobitz 2 AV block or complete heart block with broad QRS or a ventricular pause, then we continue and we repeat the step 3 and we give 0.5 milligrams of atropine. We reassess and proceed to step 4. If the rhythm is still one of these 4, then in step 4 you can choose between 3 options. The first option is we can repeat the atropine 0.5 milligrams, or we can choose for adrenaline 0.01 milligrams, or we can choose for isoprenaline. Personally, I prefer to give adrenaline 0.1 milligrams. After this, you reassess and you repeat this step until the patient is stable. We finished the bradycardia algorithm. Now we start with a new chapter. It's the tachycardia algorithm. You see in this slide the complex algorithm. The first thing we do is we look at the QRS complex. You have 2 options. The first option is that the QRS complex is narrow, and the second option is that you have a broad QRS complex. In this slide, you see a normal QRS complex down below. So this is the normal version, and it's either more narrow or more broad. The first case we will discuss is the broad and irregular QRS complex. You have 2 options, 2 pathways. The first pathway, if you have an atrial fibrillation with a bundle branch block, you give automatically a beta blocker or diltiazem. Consider digoxin or amiodarone if evidence of heart failure. The second pathway is if we have a polymorphic ventricle tachycardia. Then you give magnesium 2 grams over 10 minutes. The second case is the broad and regular QRS. You have 2 pathways. The first pathway is ventricular tachycardia. If you have a ventricular tachycardia, then you give amiodarone 300 milligrams over 20 minutes. After this, you repeat and you give 900 milligrams over 24 hours after reassessing. The third case is a narrow and regular QRS complex. When you see this, you give adenosine 6 milligrams IV rapid IV bolus. After this, you also perform vagal maneuvers. After this, you reassess, and if you have a normal sinus rhythm, probably it is a re-entry paroxysmal supraventricular tachycardia. The fourth and last case is the narrow and irregular QRS complex. For example, atrial fibrillation. When you have atrial fibrillation, you admit a beta blocker or diltiazem. You can choose. You should also consider digoxin or amiodarone if there is any evidence of heart failure. Thank you for watching. If you have any questions, you can always leave a comment below.